Welcome to the Hospital Medicine Unplugged podcast. Today we are conducting a deep dive into a clinical entity that really haunts the wards and clinics in equal measure. We are talking about the patient who presents with welts, itching, and anxiety, having been told by 3 previous providers that they must be allergic to their laundry detergent. We are discussing chronic spontaneous urticaria, or CSU.
It is good to be here. And I think this is a topic that is really ripe for a deep dive because the ground has just completely shifted beneath our feet.
It really has.
If you trained more than 5 or 10 years ago, your mental model for this condition is likely, well, Benadryl and reassurance.
Exactly.
You might view it as a nuisance condition, something to just patch up and send out.
Right, the old Benadryl and reassurance model. But looking at the source material we have today, which includes the 2024 JAMA review, the 2025 FDA Orange Book updates regarding new biologics, and the recent international guidelines from the Journal of Allergy and Clinical Immunology, that model is just obsolete. We are moving toward a structured, immunologically driven management strategy.
We really are. We're seeing a fundamental shift in how we understand the pathophysiology. I mean, this is no longer just about histamine release or, idiopathic hives.
It's about specificity.
It's about specific autoimmune endotypes. And with the approval of agents like remibrutinib and dupilumab in 2025, we have precision tools we just didn't have before. It's a whole new ballgame.
Let's start at the beginning then. The definition and the epidemiology. I think there is often confusion, even among physicians, between acute and chronic urticaria, especially in a busy primary care or hospital setting.
Oh, absolutely.
You see hives on the chart, and the immediate assumption is, an allergic reaction to a new medication or something the patient ate.
And that differentiation is strictly time-based, and it's really the first, most important branch point in your clinical reasoning.
So what's the magic number?
The key metric is the 6-week threshold. It's that simple. If wheals, angioedema, or both have been present for less than 6 weeks, it is by definition acute.
And beyond that?
If it persists beyond 6 weeks, we classify it as chronic. That's the line in the sand.
And that distinction is just so crucial for prognosis, isn't it? I mean, for managing patient expectations.
It is. There is a common fear among patients, and frankly some providers, that any case of acute urticaria is the beginning of a lifelong struggle.
Right. They see hives and they think, this is my life now.
Exactly. But the data shows that the progression from acute to chronic urticaria occurs in less than 8% of cases.
So a very small minority.
A very small minority. The vast majority of acute cases are self-limiting and do not become CSU. They just burn out.
That is a very helpful statistic for counseling patients. I mean, when a patient comes in panicking on day 4 of a reaction, we can tell them there was a greater than 90% chance this resolves completely before ever hitting that chronic mark.
And that's incredibly reassuring. It reframes the whole conversation.
Now, regarding prevalence, how common is CSU in the general population? We see a lot of hives, but how much of it is this chronic entity?
Well, the lifetime prevalence of any urticaria is actually quite high, around 20%.
So 1 in 5 people.
1 in 5 people will experience hives at some point in their life. However, CSU specifically, this chronic form, affects approximately 1% of the global population.
Still quite common. When you think about it, that's millions of people.
It is, and looking at the demographics, it seems to have a very specific predilection. It's not random.
Who is the typical patient walking into your clinic?
It's predominantly a disease of females. About 70% of patients are female.
70%, that's a strong signal.
A very strong signal, and the peak incidence occurs between the ages of 30 and 50. So the classic phenotype is a working-age woman.
Which also has major implications for quality of life, work productivity.
Huge implications. It's also important to note that it's relatively rare in the pediatric population. Less than 15% of cases occur in patients under 19 years old.
So if we see a middle-aged woman presenting with hives lasting more than 6 weeks, that is the classic phenotype, right in the textbook.
That's your bullseye.
But if we see it in a child, or perhaps an elderly male, we might need to keep our differential a little bit broader.
Precisely. You should think a little harder in those atypical demographics. Make sure you're not missing something else.
Okay, let's move into the pathophysiology, because this is really where the source material highlights what they call the end of idiopathic.
Yes.
For a long, long time, we called this chronic idiopathic urticaria, or CIU.
We did, and in many places, that term is still used on charting and in older literature, but Idiopathic implies we don't know the cause.
It's a shrug diagnostically.
It is. The nomenclature has shifted to chronic spontaneous urticaria to reflect the nature of the lesions appearing without a specific external trigger, like cold or pressure. That's what spontaneous means.
Okay, so it's not induced by an external physical stimulus.
Right. However, saying it's idiopathic, meaning the cause is truly unknown, is becoming factually incorrect for a large subset of these patients.
And the sources mention a pretty staggering number. More than 50% of patients have identifiable autoimmune endotypes.
That is the aha moment in this field. This is the paradigm shift. We're moving away from viewing this as some unexplained allergy and viewing it as systemic autoimmunity.
So it's an internal process.
Exactly. We now categorize these into two main autoimmune endotypes, type 1 and type 2b.
Let's unpack those. Start with type 1 autoimmune, which is also called autoallergic CSU.
Right. So type 1 is mediated by IgE autoantibodies. In a classic allergy, you have IgE against, say, peanut or pollen.
An external antigen.
An external antigen. In type 1 CSU, the patient produces IgE antibodies against autoantigens proteins within their own body.
What kind of autoantigens are we talking about?
Specific targets that have been identified include thyroid peroxidase TPO and interleukin 24. So the mechanism is standard mast cell degranulation via IgE, but the trigger is internal.
So the machinery is the same as a traditional allergy. The mast cell is exploding because IgE told it to, but the phone call is coming from inside the house.
That is the perfect analogy. Absolutely perfect. And then we have type 2b autoimmune CSU. This one seems to be a more distinct and perhaps more severe phenotype.
Describe the mechanism there. It's different, right? It's not IgE mediated in the same way.
It's not. Type 2b is mediated by IgG autoantibodies, so a different class of immunoglobulin.
And what are these IgG antibodies targeting?
They're doing one of two things. These IgG antibodies can target the IgE molecule itself, or, and this is key, they can target the high-affinity receptor on the mast cell, which is the Fc epsilon R1.
So instead of using IgE as a bridge to activate the receptor, these IgG antibodies are just directly activating the receptor itself or the IgE that's already sitting on it.
Correct.
They're hot wiring the receptor.
Exactly. They are hot wiring the receptor. It functionally mimics a type 2 hypersensitivity reaction, like in autoimmune hemolytic anemia. It's a direct antibody-mediated activation.
How common is this specific endotype?
The prevalence of this specific type 2b endotype is about 8 to 10% of patients. But that's if you use very strict triple positive criteria.
What are those criteria?
That includes a positive autologous serum skin test, specific immunoassays for the antibodies, and basophil activation tests. So it requires a pretty specialized workup to definitively prove.
And why does distinguishing between type 1 and type 2b matter clinically? I mean, does it actually change how we treat them?
It absolutely does, and we'll get into the weeds on that in the treatment section. But just as a general rule, patients with type 2b autoimmunity, the IgG-mediated type, tend to have more severe disease.
More severe hives, more frequent outbreaks.
Yes, and they're often less responsive to standard antihistamines, and importantly, even less responsive to our first-line biologic omalizumab, which targets IgE.
Well, that's a critical clinical pearl. If your drug is mopping up IgE, but the disease is driven by IgG activating the receptor directly,
the drug is mechanically mismatched to the pathology.
it's destined to have a limited effect.
Correct. And it's worth noting that the data shows less than 35% of patients have no detectable autoantibodies at all. So for the majority of cases, we can find an autoimmune driver. This really shifts the view of the disease from unexplained allergy to systemic autoimmunity.
With that reframing, let's talk about the diagnostic approach. It has to change if we're thinking about it as an autoimmune disease. The guidelines mention this 7C concept.
Yes, the 7C concept is really just a framework, a mental checklist to ensure a comprehensive evaluation.
Can you walk us through it?
Sure. It stands for confirmation of the diagnosis, cause identification where possible, assessing for cofactors that might worsen it, checking for comorbidities like thyroid disease, evaluating the consequences, meaning the impact on quality of life assessing components or biomarkers, and finally, monitoring the course of the disease over time.
It's a very systematic way to think about it.
It is. It prevents you from just focusing on the hives and forces a more holistic view of the patient.
Now, in the spirit of choosing wisely, the sources are very, very specific about the laboratory evaluation. I think there's this tendency, a reflex really, to order a massive panel food allergies ANA, infectious disease panels.
The shotgun approach.
The shotgun approach. We want to find the smoking gun.
And the guidelines explicitly advise against that. Extensive routine testing is not recommended unless there's a specific clinical suspicion based on the history. It's low yield.
So what does that recommended limited workup actually look like?
It's refreshingly simple.
Wow.
First, a CBC with differential. You want to look at the eosinophils and basophils.
Okay.
Second, an ESR or CRP, just a basic inflammatory marker.
To see if there's systemic inflammation.
Exactly. And third, a TSH.
And the TSH makes perfect sense, given the strong link to autoimmune thyroid disease and TPO antibodies that we just mentioned.
Exactly. The association with thyroid autoimmunity is one of the most robust findings in the literature. But checking for, say, H. pylori or stool ova and parasites, or these comprehensive food allergy panels in a patient with chronic symptoms and no clear dietary link, it's just low yield, and it often leads to more confusion.
Oh, I see this constantly. Patients come to me with pages of IgG food allergy results that show low-level positivity to everything from wheat to strawberries.
The ones that aren't validated for this indication.
Right. And they've restricted their diet to rice and water. They're miserable, and they still have hives.
Because CSU is rarely a classic IgE-mediated allergic reaction to food. It's autoimmune. The testing just leads to false positives, unnecessary and often harmful lifestyle restrictions, and it distracts from the real pathology.
Okay, that's a key point. Let's pivot to the red flags for referral. When should a hospitalist or a generalist start to worry that this isn't just CSU and something more sinister might be going on?
This is critical. First, you need to watch for wheals that last 24 hours or longer. This is probably the single most important sign.
Why is that so important?
In classic CSU, the individual lesions are famously transient. They're migratory. They move around, they vanish, they reappear elsewhere. If a single lesion stays put for a whole day, you should be very suspicious of vasculitis.
Okay, duration of the individual lesion. What's next?
Look for what's left behind. After a CSU hive fades, the skin should look normal. If there's post-inflammatory hyperpigmentation, like a bruise or a stain left behind, that's another major red flag for vasculitis.
And what about systemic symptoms? What should we be asking about?
Things like fever, significant arthralgia, or bone pain are not features of uncomplicated CSU. If you hear those, you need to broaden your differential to include autoinflammatory syndromes or even underlying malignancies.
What about angioedema?
That's another one. If there's angioedema without wheals, and especially if it's refractory to antihistamines and lasts for days, you must consider bradykinin-mediated conditions. Things like hereditary angioedema or ACE inhibitor-induced angioedema. It's a different pathway.
This leads us naturally into the most important differential diagnosis, which is urticarial vasculitis. The sources really emphasize this differentiation as a critical safety step.
It is the most important differential to rule out without question, because urticarial vasculitis, or UV, can be a cutaneous manifestation of a serious systemic disease like lupus, Sjogren's, or cryoglobulinemia. Missing it has major consequences.
So how do we differentiate them clinically at the bedside, aside from that duration of the wheal we talked about?
The sensation is a big clue. CSU is intensely pruritic. It itches. Patients are driven mad by the itching. Urticarial vasculitis is often described as painful or burning.
So ask the patient, does it itch or does it hurt?
It's a simple but powerful question. And then, again, the resolution of the lesion. As I mentioned, CSU leaves normal skin. UV leaves that residual purpura or hyperpigmentation, which is often described as a nutmeg appearance. It looks like a faint bruise.
The UCARE study provided some very specific and powerful odds ratios regarding these symptoms.
Yes, that data is incredibly compelling and clinically useful. They found that if the wheals last 24 hours or more, the risk of urticarial vasculitis increases 7.3-fold.
That's a huge increase.
A huge increase. If there is skin pain instead of just itching, the risk increases 7.0-fold. And if there is post-inflammatory hyperpigmentation, the risk increases 4.1-fold.
So if a patient sits in front of you and says, my hives hurt, they last for 2 days, and they leave a bruise, that is urticarial vasculitis until proven otherwise.
100%. You need to biopsy that patient.
And the diagnostic confirmation is that skin biopsy. What are you looking for?
You're looking for the classic histopathological findings of leukocytoclastic vasculitis. That means neutrophilic infiltration of the vessel walls, fibrinoid necrosis. It's a destructive process.
The sources also mention dermoscopy as a potential bedside tool.
This is a really interesting finding. Apparently, visualization of purpuric patches or globules on dermoscopy increases the odds of UV 19-fold.
19-fold.
19-fold. It's a very strong predictor, so if you have a dermatoscope handy, it could really help guide your decision to biopsy.
Before we leave this differential, just a brief word on a specific subtype. Hypocomplementemic urticarial vasculitis syndrome, or HUVS.
Right, HUVS. That's a more severe systemic form of UV. It's defined by urticaria for more than 6 months, plus hypocomplementemia specifically, you'll see low C3, C4, or C1q levels.
And this has systemic consequences.
Major systemic involvement. These patients can have venulitis, glomerulonephritis, uveitis, even pulmonary disease. It is a multi-system autoimmune disease that you absolutely do not want to miss.
So check a complement level if the picture is suggestive.
Absolutely.
Okay, let's move to severity assessment. We're trying to move beyond just asking, how are you feeling, and toward using objective, validated metrics.
Right. Subjective reporting is notoriously unreliable, especially in a fluctuating condition like CSU. A patient might come in on a good day and say they're fine, or on a bad day and say they're miserable, and it doesn't capture the whole picture.
So what's the gold standard?
The gold standard is the UAS7, which stands for the Urticaria Activity Score over 7 days.
How is that calculated? Is it something the patient does at home?
Yes, it's a patient-reported outcome. The patient scores 2 parameters, itch intensity and hive count. Both are scored on a simple scale from 0 to 3.
And how often do they do this?
They do this twice daily, morning and evening. The maximum score for any given day is 6, so over 7 days, the maximum possible score is 42.
And what do those scores mean? What constitutes severe disease?
A score of 28 to 42 is considered severe. Well-controlled disease is anything from 1 to 6. A score of 0 means they're completely symptom-free.
So it gives us a concrete number to track their response to therapy.
Exactly. It's invaluable for clinical trials, but also for clinical practice.
Yeah.
It helps you justify escalating therapy to insurance, for example.
There is also another tool mentioned, the UCT, or the Urticaria Control Test.
That one's a bit simpler. It's a 4-item retrospective tool. It asks about symptoms and quality of life over the past 4 weeks.
What's the key cutoff there?
A score of 12 or higher indicates well-controlled disease. Anything less than 12 suggests poor control and that we need to be more aggressive with therapy. It's a quick snapshot of their recent disease state.
Speaking of escalating therapy, let's dive into the management strategy. This is where I think many of our peers might be surprised by the current guideline recommendations, especially on dosing.
I agree. This is where practice often lags behind the evidence.
So what's the foundation? Where do we start?
The foundation remains second-generation H1 antihistamines. We're talking about agents like cetirizine, loratadine, fexofenadine, levocetirizine, and desloratadine.
And the dosing strategy is absolutely critical here, isn't it?
It is non-negotiable. These must be taken daily. Scheduled, not PRN, not when I feel an itch coming on. The goal is constant receptor occupancy to prevent the entire inflammatory cascade from starting.
You're trying to prevent the fire, not put it out after it started.
Precisely. Taking it as needed is a failing strategy from the start.
But we all know that standard FDA-approved dosing only works for a fraction of these patients.
That's right. The data shows that only about 40% of patients achieve a partial or complete response with the standard once-a-day dose.
So for the other 60%, what is the next step? This is the key question.
The international guidelines are very clear and have been for years. You increase the dose up to 4-fold.
4 times the standard dose. I still see a lot of hesitancy about this in practice. People get nervous. Is it safe?
It is extremely safe. The second-generation antihistamines have a very, very wide therapeutic window. They are highly selective for the H1 receptor and don't cross the blood-brain barrier significantly, which is why they're non-sedating.
And importantly, the evidence shows that quadrupling the dose of a single agent is superior to another common practice, which is mixing different antihistamines.
Yes, this is a crucial point.
So you're saying don't have the patient take cetirizine in the morning and fexofenadine at night?
No. That is less effective. If your patient is on 10 milligrams of cetirizine and still symptomatic, you go to 20 milligrams and then potentially up to 40 milligrams a day.
And there's good data for this.
There's a prospective randomized controlled trial that directly compared these two strategies. It showed 40% complete control with high-dose monotherapy versus only 10.7% control with the strategy of mixing 4 different antihistamines.
It's a huge difference.
It's a massive difference. Up-dose, don't mix. It's more effective, simpler for the patient, and we have robust safety data for it.
That is a definitive Practice-changing takeaway.
Mm-hmm.
Now, if the patient fails 4 times the standard antihistamine dose, we move to second-line therapy. And this is where the biologics come in.
Right. This is for the antihistamine refractory population. The standard of care here, our first-line biologic, is omalizumab. That's omalizumab.
And what is omalizumab's mechanism?
It's a monoclonal antibody that targets and binds to free IgE in the circulation.
So it takes the Ig out of play before it can ever bind to the mast cell.
Exactly. It reduces the amount of IgE available to load onto the Fc epsilon R1 receptors, which in turn causes those receptors to downregulate on the surface of mast cells and basophils. It makes the cells less trigger-happy.
What's the standard dosing for CSU?
For CSU, it's 300 milligrams administered subcutaneously every 4 weeks. This is for patients age 12 and older.
And what does the efficacy data look like for omalizumab? How well does it work?
It's quite good. A large meta-analysis of 7 randomized controlled trials showed a 36% complete response rate, and that means a UAS7 of 0, completely clear skin.
36%.
Compared to just about 5 to 6% for placebo. So a very significant benefit. And what's interesting is that in real-world observational studies, the response rates are often even higher.
Why is that?
Probably because in the real world, we can adjust dosing and we're not bound by strict trial protocols. We see rates of partial or complete response getting up towards 70 or even 75%.
However, there's a significant cohort of non-responders.
Yes. About 30% of patients do not respond well to omalizumab, and this connects right back to our pathophysiology discussion earlier.
The different endotypes.
The different endotypes. The non-responders are often those patients with the type 2B autoimmune endotype, the ones with the IgG autoantibodies, and typically lower total IgE levels.
It makes perfect mechanistic sense.
It does. Since omalizumab's entire mechanism is based on targeting IgE, if your disease is primarily driven by IgG directly activating the mast cell receptor, the drug is going to be mechanically less effective.
You're targeting the wrong pathway.
You're targeting the wrong pathway. For those patients who are partial responders, is there any room to adjust the omalizumab dose? Yes, for partial responders, there is evidence and guideline support for either increasing the dose to 600 milligrams every 4 weeks or shortening the interval to 300 milligrams every 2 weeks. But for the true non-responders, we really need to switch to a different target.
And this brings us to the most exciting part of this deep dive, the emerging therapies and the 2025 approvals. What do we do for those 30% who fail omalizumab?
Until very recently, our options were limited and, frankly, not great. We'd often have to reach for broad immunosuppressants like cyclosporine. But now we have new targeted tools. Let's start with dupilumab.
Dupilumab, an agent we're all familiar with from atopic dermatitis and asthma.
Exactly. It's an anti-IL-4 receptor alpha antibody. It blocks signaling from both interleukin-4 and interleukin-13.
So it's targeting the Th2 inflammatory axis.
Precisely. And it was approved in the U.S. for CSU in 2025 for patients who are refractory to H1 antihistamines. The pivotal trial data showed a 31.4% complete response rate at week 24. So it's another very effective option.
But perhaps even more novel, mechanistically speaking, is the introduction of the BTK inhibitors. Let's talk about remibrutinib.
Remibrutinib is a fascinating and game-changing addition to our armamentarium. It was FDA approved in September 2025. It is a Bruton tyrosine kinase, or BTK, inhibitor.
How does this mechanism differ so fundamentally from the monoclonal antibodies?
Well, instead of trying to mop up the IgE or the cytokines outside the cell, remibrutinib is a small molecule that works inside the mast cell.
An intracellular target.
An intracellular target. BTK is a critical signaling molecule that sits downstream of the Fc epsilon R1 receptor. When that receptor gets cross-linked, it sends a signal through BTK to tell the cell to degranulate and release histamine.
So it's blocking the signal regardless of what pulled the trigger on the outside.
Precisely. It doesn't care if the receptor was activated by an autoallergen via IgE, as in type 1 disease, or by an IgG autoantibody directly, as in type 2b disease. The BTK inhibitor stops that final signal from causing degranulation.
It cuts the phone line inside the cell.
It cuts the phone line, and that implies it should work for both of the major autoimmune endotypes.
And does the data support that?
The data absolutely supports that. The complete response rates in the trials were between 26 and 42% at week 12. But what is really, really impressive is the speed of onset.
How fast were we talking?
We see a rapid onset of action, a significant reduction in symptoms as early as week 2.
Week 2. That is a massive advantage for patients who have been suffering, sometimes for months or years, on other therapies.
It's a huge psychological and physical benefit, and most importantly, it offers a highly effective solution for that difficult-to-treat type 2B cohort that was destined to fail omalizumab.
What about third-line options? For those who might not have access to these brand-new agents yet, or who might even fail them, we still have the old workhorse, cyclosporine.
We do. Cyclosporine, or cyclosporin, is the classic third-line agent for refractory CSU. It's used off-label, typically dosed at 3 to 5 milligrams per kilogram per day.
It's effective, there's no question, but it comes with significant baggage.
Very significant baggage. It improves symptoms in 54 to 73% of patients, and it seems to be particularly effective in that autoimmune population, which makes sense given its mechanism.
But the side effects?
The adverse event rate is high. Up to 57% of patients experience issues like hypertension, elevated creatinine, headaches, or hirsutism. It's a potent, non-specific T-cell inhibitor.
So it requires very careful monitoring.
Yes, you absolutely need to be monitoring blood pressure and renal function, that creatinine, on a regular basis. This is not a drug you can start and forget about. It requires a committed physician and a committed patient.
And just to close out the treatment section, let's clarify the role of systemic corticosteroids one more time.
They are for crisis management only. Short courses, 20 to 50 milligrams of prednisone or equivalent for less than 10 days, are appropriate for acute, severe exacerbations to get a patient out of trouble.
But they have no role in long-term management.
Absolutely no role. The well-known adverse effect profile, osteoporosis, weight gain, diabetes, cataracts, makes them completely unsuitable for long-term maintenance of a chronic disease. We must get patients off chronic steroids.
Let's round out this deep dive with prognosis. What do we tell our patients about the natural history of this disease? What can they expect?
This is a really important conversation to have. The mean duration of the disease is usually 1 to 4 years, so it's not typically a lifelong condition for most people.
And the remission rates over time.
The data shows that at 1 year, only about 17% of patients are in remission.
That's not very encouraging for someone at the beginning of their journey.
It's not, and it's important to set that expectation. But by 5 years, that number goes up to 45%, and by 20 years, 73% are in remission. So the good news is that for the vast majority, it does eventually burn out, but it takes time.
Are there certain factors that predict a longer, more protracted course?
Yes, there are. If the patient has concomitant angioedema, if they have very high disease severity scores at baseline, like a high UAS7, or if they have the presence of antithyroid antibodies, they are statistically more likely to have a longer duration of disease.
And even after they achieve remission, recurrence is common.
Relapse occurs in up to 1/3 of patients, even after they've achieved what we call clinical remission.
How do you define clinical remission?
We define that as the complete resolution of symptoms without any pharmacotherapy for more than 6 months. So even after 6 months of being clear off meds, there's still a chance it can come back.
This has been an incredibly comprehensive and practice-changing update. Let's try to summarize the biggest key takeaways for our listeners.
I think number one is that CSU is rarely allergic. It is autoimmune. We have to get out of the mindset of looking for the elusive food trigger and start treating the immune system.
Okay, that's the big paradigm shift. What's number 2?
Second, do not fear the 4-fold antihistamine dose. It is safe, it is effective, and it is explicitly recommended by international guidelines. Updose, don't mix.
A very practical point. Number 3.
Third, we must differentiate CSU from urticarial vasculitis. Remember the 24-hour rule for lesion duration. Ask about pain versus itch, and look for that nutmeg staining. Missing UV is a major risk.
And finally,
for those antihistamine refractory patients who fail omalizumab, we have entered a new era. With the approval of remibrutinib and dupilumab, we have targeted highly effective options. We are no longer stuck.
it really feels like we are finally offering these patients true precision medicine rather than just blanket symptom suppression.
That is exactly the goal. We're moving from a sledgehammer to a scalpel.
Before we sign off, I want to leave our listeners with a provocative thought to mull over. With the advent of these BTK inhibitors and our much better understanding of type 2B autoimmunity, are we moving toward a future where we treat urticaria not by suppressing the symptom histamine, but by actually turning off the specific autoimmune switch upstream? Is the future of dermatology and allergy actually rheumatology?
That is the question that is going to define the next decade of research in this field. And with agents like BTK inhibitors that bridge that gap between mast cell biology and B-cell signaling, I think we are already seeing the beginning of that merger.
Thank you for listening to this deep dive on Hospital Medicine Unplugged. Stay curious.
And keep questioning.